The next bill that we are going to take is House File 2500, and Representative Faulkner, you are on the committee, and you are also the bill's chief author. We have 4 testifiers, and as we are getting ready to have Representative Faulkner go to the testifying table, I'd ask that you go ahead and also bring your testifiers forward, and I will move House File 2500 before the committee. And Representative Faulkner, there's also a DE1 amendment in here. I'm assuming that DE1, by its nature, is an author's amendment. Am I correct on that?
Yes, thank you, Chair.
Yep, and as a member of the committee, you certainly can move your DE1 amendment for consideration.
Yeah, thank you. I move the DE1 amendment.
Representative Faulkner moves the DE1 amendment to House File 2500 to get the bill in the shape that the author wishes. All those in favor signify by saying aye.
Aye.
Those opposed, the motion prevails. Representative, you are teed up and ready to go here on House File 2500.
All right, thank you, Chair. Realizing time, I'll try to keep this quick. Thank you for taking time with your gavel also to hear this bill. I really do appreciate it. This bill came to me when UHG, which is the largest nation's largest health insurance provider, was rocked by revelations, investigations, and lawsuits alleging that their AI software program, predict, was knowingly and errantly denying claims for physician-ordered care. Plaintiffs alleged their AI tool had a 90% error rate, and that United Health continued to use it knowing it was deeply flawed and even pressured employees to continue using it regardless. United Health continued, I will state that their lawyers deny this claim. It is moving through the courts. A federal judge allowed the lawsuit to proceed in 2025. The lawsuit claims United Health used their AI to create a monetary windfall by denying care, knowing that only a minuscule percentage, which is roughly 2% of patients, would actually appeal. During that same time, for those that don't know, I coach during 2 seasons in schools in my district. During one afternoon's practice, a student was visibly struggling, so I went up to check on her. She was pale, disoriented, and clearly needed to stop. She described how normally her insulin pump would keep her blood sugar regulated so she could attend and participate almost as if normal. But her insurance company denied paying for her pump's timely refill. And however, she, as almost any high school athlete I know, decided, I'm just going to gut it out, see what happens, and learn the hard way after a hospital visit that wasn't the best idea. Though, of course, none of this fault should be laid at the feet of a child. UHG had put in place a system that systematically denied physician-ordered care with the benefit of padding their $22 million in profits that year, and potentially cost one of my athletes their life, but certainly did cost them an unnecessary and avoidable hospital visit. Is AI inherently bad? Well, of course not. I mean, but a computer program, just like a corporation, is a creation of humankind. The legal code baked into a corporation is to maximize profit for shareholders' benefit. That's their literal legal reason to exist. AI, also a human creation, is a software code designed to do the bidding of its creators. Whether the software is operating correctly or not, the ramifications happen at scale given the massive and rapid adoption. Major corporations are utilizing the potential to streamline processes to maximize shareholder value. AI done right can have tremendous benefits. And with regards to pre-authorization requests, AI can be used for good, and that's what my author's amendment sought to reflect. It can speed up paperwork processing time, scan forms to make sure they're filled out correctly and completely, be used to standardize paperwork and systems across the board, etc. Used right, AI can and does move prior authorization requests forward faster, delivering the results both doctors and patients want, need, and expect. However, there is growing concern about continuing to allow health insurance companies to leverage AI in making adverse decisions regarding pre-authorization requests. This has resulted in an unacceptable number of flawed results, such as the one that happened to one of my student athletes, and apparently enough other patients to spark an investigation and lawsuit landing on the front page of major newspapers across the country, massively decreasing the stock value and profits of the largest insurance company in the country. I also do feel, though, that it's important to acknowledge that healthcare is not just a business. It's a deeply human endeavor. The decisions made about patient care, treatments, and interventions impact real lives, including everybody in this room. Relying on algorithms to dictate who receives care can strip away the nuanced understanding that medical professionals bring to the table, an understanding that goes beyond mere data points. AI systems, no matter how advanced, lack the empathy, compassion, and real-world experience that are fundamental to effective and personalized healthcare. Moreover, the use of AI in pre-authorization processes runs the risk of perpetuating existing biases and inequalities. AI systems learn from historical data. They're trained on what we know now to solve a problem or to work forward. AI systems, but this can reflect systemic biases that's in that data set right now. For example, Black and brown and indigenous women are twice as likely to die from complications during pregnancy. When insurance companies use these algorithms to deny coverage, that data set that led to those results potentially is baked into that system. They may unintentionally reinforce these disparities in healthcare access for marginalized groups. When the system is unable to learn the moral ramifications of decisions that are baked in, that went into the decision-making process, they're not going to be able to correct for the future. The lack of transparency surrounding AI decision-making makes it nearly impossible for medical professionals and patients to appeal, also to appeal adverse decisions, and the very essence of patient-provider relationships is stripped away. These relationships are built on trust, communication, and shared decision-making, and a human-to-human understanding of the ramifications of an incorrect diagnosis or treatment plan. If an AI system becomes the gatekeeper for necessary medical care, it diminishes the relationship between patients and their healthcare providers. Patients lose faith in a healthcare system that prioritizes efficiency, cost savings, and shareholder value over personalized care. They face insurmountable obstacles to attempt the appeals process. They're required to pay for expensive life-saving treatments while trying to navigate that same process out of pocket, hoping to get reimbursed someday, or are too often times forced to forego treatment altogether. A majority of patients surveyed reported their conditions significantly worsened as a result of the delayed denial initiated by the AI-driven system. As a reminder, it's alleged that 90% of denials were wrongly issued, and that only 0.2% of patients went through the appeals process. More than half didn't even know that they had the option to appeal, should they have had the time and resources to initiate and track the process to conclusion. In conclusion, a software program built to maximize profit by denying physician-ordered care is immoral, unethical, demonstrably results in worsening patient care outcomes, erodes trust in what should be an inherently human system, has led to death, forced early discharges, perpetuates systemic biases, shifts undue burden onto patients and providers, increasing their real-world expense, making their lives, in turn, and businesses more unaffordable. But here's the good news. It's at least relatively easy to solve. We can and should disallow computers from overriding medical professionals. We can and should return to a human-centric system of evaluating these potential denials and working to find a solution that works for both the patient and provider. I think the pre-authorization system could use quite a bit of reform. I feel like this is just a small angle of it, but a good step forward. And so with that, I will end my remarks, allow testifiers to come up, and we'll stand for any questions.
Thank you, Representative Faulkner. And the first testifier we have is Dr. Krishan Sabanam, if I'm not mistaken, from the Hennepin County Chief Medical Officer with Hennepin Health. Welcome to the committee. If you'll state your name for the record, and I apologize for my pronunciation of your name if I butchered it.
No, thank you, Mr. Chair and committee members. Good morning. My name is Dr. Krishnan Subramanian. I'm a pediatrician at Hennepin Healthcare and the Chief Medical Officer at Hennepin Health, which is the state's only county-owned managed care organization. I represent a county and an organization that ensures that 35,000 incredible neighbors and some of the most vulnerable neighbors have access to health care and health coverage. We have no commercial component. We pay for medical care with Medicaid dollars. Recently, I cared for a young man with a rare illness. The medication he needed that had been shown to work had an extraordinarily high cost. As someone unable to work, he did not have private health care insurance. Covering that treatment came at a real cost to taxpayers. These are not decisions that should be taken lightly. But in this case, our request followed state guidelines. It was approved. The treatment worked, and it provided life-saving treatment. If AI can facilitate and expedite approval of care for folks, great. However, we do find it troubling if AI algorithms are being used to deny care. When taxpayer dollars are funding care, and complex clinical decisions are being reviewed, that sacred relationship between providers and patients deserves a meaningful review, one that considers the full clinical picture, the lived experience of the patient, and importantly, the consequences of getting it wrong. When human lives are at stake, humans need to be involved. That is why we support the requirement of a human being be involved in any denial of care. We support HF 2500 and today's amendment to ensure that when care is questioned, it is done with a real human impact fully understood. Thank you, Mr. Chair.
Thank you for your testimony, Doctor. And with that, we'll bring up Chad Fonning as our next testifier. And then following Mr. Fonning will be Ann New Brindley.
Who? Who's that?
An Ann New Brindley is on deck. Welcome, Mr. Fonning, to the committee. If you'll state your name for the record and proceed with your testimony.
Thank you, Chair and members. My name is Chad Fanning with the Minnesota Medical Association. The MMA is the largest professional association advocating for doctors in Minnesota, representing over 10,000 physicians across the state. I am here to testify in strong support of House File 2500 as amended. We have worked a lot on prior auth reform over the years, most recently advancing legislation in 2024. Most of that law went into effect earlier this year, but one thing that was not addressed previously was the use of AI in prior auth. It is our position that if there is an adverse determination, that decision should be made by a reviewing health provider of a same or similar specialty, not a computer denying or delaying care based on an algorithm. We have extensive data showing that prior auth is a top cause of frustration by both patients and providers. About 70% of patients say that prior authorization is burdensome, with the majority saying that it is the top barrier to receiving care. For our members, according to national data, 94% of physicians reported that prior auth requirements delay access to necessary care, with 82% indicating that delays lead to patients abandoning recommended treatments altogether because there are simply too many hoops to jump through just to get their prescribed treatment. Nearly 1 in 4 physicians report that prior auth has led to a serious adverse event for a patient, including hospitalization, permanent impairment, or even death. These are serious decisions that need to be made by a trained healthcare provider, not a computer. I appreciate the opportunity to testify on this issue. The state's physician community strongly supports this bill. However, we would suggest one change. The bill currently lives in Minnesota Statute 62A, regulating the use of prior authorization. We would suggest at a future date, shifting that language and duplicating it in 62M so it applies to all utilization review. Nonetheless, this bill is a great step forward. It will help patients get the care that they need and ensure that doctors are doing what they do best, that is treating patients. Thank you for the opportunity to testify. Happy to answer any questions.
Thank you for your testimony this morning, sir. We'll have you stand by in case there are questions. And then our next testifier is again Ann New Brindley, followed by Dan Andreessen. Good morning, Ms. New Brindley. If you'll state your name for the record and proceed with your testimony. Why do I know that name?
It's a mystery.
Okay.
I know you're all just have missed me desperately. Thank you, Mr. Chair and members. My name is Ann New Brindley, and I represent the Minnesota Business Partnership. We are an organization of business leaders from across the state whose companies employ more than 500,000 Minnesotans. MBP is committed to a strong economy, affordable health care, and access to high-quality, evidence-based care for all Minnesotans. We appreciate the author's DE amendment, limiting the prohibition of the use of algorithms and AI to apply only to adverse determinations, and delaying the implementation represents significant change from the original proposal and addresses several concerns. We share the goal of ensuring that prior authorization denials are fair, clinically appropriate, and involve meaningful human judgment. At the same time, we oppose barriers to innovation that can improve health outcomes and reduce costs. Even as amended, the prohibition on algorithm or AI use in adverse determinations raises concerns. And most importantly, there is no clarity on what it means to use algorithms and AI. In practice, these tools are often used to support human reviewers. They are used to apply clinical guidelines consistently, identify missing information, and streamline those reviews. They are not used to replace clinical judgment, but even the new language may prevent this beneficial use of those tools. Now, I want to acknowledge Representative Falconer's opening comments that I think clearly indicate that it is not your intention to limit the use of those tools in those ways, but you all know that I'm a stickler for words and language, and the language as it is written does not reflect that and has serious concerns. So we do appreciate the changes made through the DE amendment. We also remained focused on ensuring that policies protect patients while allowing innovation that supports access, affordability, and better health outcomes. Thank you, Mr. Chair.
Thank you, Ms. New Brindley, for your testimony, and Mr. Dan Andreessen will be the final testifier that we have for our pre-logged list. And again, if there's anyone in the audience that wishes to testify in this matter, go ahead and identify yourself right now. We'll get you in queue. Anyone else wishing to testify? Mr. Andreessen.
Mr. Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans. We represent Minnesota's nonprofit insurers, which includes Blue Cross Blue Shield of Minnesota, Health Partners, Medica, and Sanford Health Plan. First, I want to thank Representative Falconer for reaching out to us to talk about this bill. We've had some construction conversations over the past year. AI is a promising technology that is being used to speed through administrative processes that humans can sometimes do, but not as efficiently. Everyone within the healthcare space is using AI. It's not just health insurers, it's also providers, hospitals, drug companies, device manufacturers. Everyone is using it in certain different ways. And health plans do use PA in order to speed up processes. But just like any technological tool, there is a limit to how you use AI, and it doesn't necessarily replace humans in some situations. And that includes adverse determinations. It has been standard practice for all of our plans that making an adverse determination is done by a licensed provider, physician, or pharmacist. We also must follow Minnesota Statute 62M.09, which also makes these requirements that a licensed provider make these final determinations. However, we know that as AI technology continues to advance, there's concerns about how it's going to be used, and we appreciate that the language is being used to limit the prohibition to just adverse determinations. This will allow health plans to continue to use this technology to speed our approval process, and we're using this technology to get us to a yes as fast as possible and not to a no. Thank you.
Thank you, Mr. Andreessen. That again wraps up those who have signed up to testify, and there was no one identifying themselves wanting to be testifying before the committee. Member questions, I have none in the queue. Is there anyone that has a burning question that would like to leave the last 20 minutes with Representative Hansen for her bill? Representative Smith.
Thank you, Chair. I'll be brief. Thank you, Representative. I think this is a great bill. I am from Rochester, a global hub of medicine, so I want to speak out with the group in the medical community that doesn't normally get a loud voice here, and that is medical residents. I have spoken to many who the mountain of digital or physical paperwork that they are buried under because of prior auth rejections. And they are the medical professionals who have to go through that and fight for their patients to get the treatment that they need. I was just talking to an ophthalmological resident who visited me yesterday, who talked about how much prior auth rejections she was working on. And she specifically mentioned, which I think is interesting in this discussion, she noticed when some of her patients were turning 85, their glaucoma medication was kind of consistently being denied. And she didn't have a reason for that. And I said, you know, we have a bill tomorrow that I think might account for this, where a computer has, you know, a statistic or actuarial data that says at 85, this medication maybe isn't good. And so instead of consulting, it's just automatically rejected. And you could see her face sort of brighten up and say, yeah, that makes sense. That's why I'm spending so much time in paperwork and not advancing my professional skills so that I can be a healthcare leader in the future. So I think this is a great bill. I'm happy to be a co-author here, and I know a lot of my constituents who are medical residents will be very excited to hear that something like this is going through the legislature. So thank you.
All right. Again, no other member questions at this time. Representative Faulkner, as we did with House File 1434 as amended, we're going to lay that one over. We also are going to lay your bill, House File 2500 as amended, over for possible consideration by future action by this committee. Thank you for your time.
All right.